From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello and welcome to our listeners around the world. You're listening to JAMA Neurology Author Interviews. Thanks for joining us. My name is Dr. Cynthia Armand. I'm Associate Professor of Neurology at the Albert Einstein College of Medicine Montefiore Medical Center and Web Editor of JAMA Neurology. Today, our topic of discussion will be migraine and comorbidity treatment, namely major depression. Joining me today is Dr. Richard Lipton, who is the lead author in the work of he and his colleagues titled Fremanezumab for the Treatment of Patients with Migraine and Comorbid Major Depressive Disorder, the UNITE randomized clinical trial. Dr. Lipton is a professor of neurology, as well as professor of psychiatry and epidemiology, and vice chair in neurology at the Albert Einstein College of Medicine Montefiore Medical Center. He is also the director of the Montefiore Headache Center. He is extensively published in topics involving migraine headache, as well as cognitive and aging dementia. Dr. Lipton, welcome to the podcast.
So happy to be here. Thank you for highlighting our paper.
Now, what we're discussing today is migraine and comorbid major depression. We do know that migraine is comorbid with many other disorders, cardiovascular disease, other CNS diseases like epilepsy, anxiety, GI disorders like irritable bowel syndrome. What made you hone in on major depression for this work?
Well, as you say, migraine does have many comorbidities, but depression is certainly one of the most common. So in headache subspecialty practice of people with migraine, perhaps 50 or 60% of them have comorbid depression. And even in population studies among people with chronic migraine, 30% have depression. So it is a major comorbidity, and clinicians frequently have to make a decision in a patient with migraine and depression, whether to first address the migraine, the depression, or both.
As a practicing headache neurologist myself, I do come across this very often. And many times I run through this dilemma in my mind of whether or not my patients should definitely be plugged into psychiatry or psychology and receive treatment for major depression itself, or just treat the migraine and see what happens. Can you tell our listeners about the evolution of treatment of migraine with comorbid depression and what the approach should be in general?
So the approach to migraine with comorbid depression has evolved somewhat. Early in my career, the teaching was if a patient has migraine and depression, the best approach might be to choose a drug that would be appropriate for both disorders. And quite often, the family of preventive treatments that we would use in that context were tricyclic antidepressants, and later maybe SNRIs as well, which are effective both for migraine and depression. There then arose a trend towards saying, rather than treating two conditions if they're present together, why not treat each condition with whatever treatment would be optimal for that condition? And so, for example, we might give an SSRI for depression and topiramate or some now oral generic medication as the preventive. And now I would say we're a little bit betwixt and between, because when it comes to the preventive treatment of migraine, we traditionally think of CGRP-targeted therapies, which are among the most widely used preventives, as treatments for migraine, but not depression. Mm-hmm. And there remains a question of whether CGRP-targeted therapies might have a role not just in making migraine better, but also in treating the depressive symptoms. So thinking has evolved, and the study we'll discuss today provides a helpful answer, but not a totally complete one.
So looking at your study, we are mainly talking about Fremanezumab. Now, we have several options. We can fortunately say that today. Several options of CGRP targeting medications. In this case, we're discussing a monoclonal antibody. What made you hone in on Fremanezumab for this study as opposed to Arenumab, Galcanezumab, Eptinezumab?
Yeah, well, part of the reason was I was involved in an earlier Fremanezumab study where our initial question was, will Fremanezumab work in the subgroup of people with migraine who have depression? And we did a post hoc analysis where we took everybody with depression and examined them as a subgroup, and that post hoc study showed that Fremanezumab was quite effective in treating migraine and depression. And we then asked the question, in the same post hoc sample, would Fremanezumab also make the depression better? And although we saw a statistically significant treatment effect on the endpoint related to migraine, namely monthly migraine days, which went down more with Frem than with placebo, we saw a trend, but not a statistically significant effect on depression. And so my reason for wanting to do the study with Frem was the previously available data showing that it would be an effective treatment in people who have both migraine and depression, and to answer the question, in a specifically designed, adequately powered study, can we make depression better also?
Very good. So let's get into the study details. How did you set this up in terms of your main outcomes as well as the patient population?
Sure. So to be eligible for the study, patients had to have a high enough headache frequency to need a preventive medication. Many migraine studies of preventives these days do separate studies evaluating episodic migraine, which is defined essentially by fewer than 15 monthly headache days, and chronic migraine, which is defined by 15 or more monthly headache days. In this study, we made an exception to the usual design and enrolled people who had either episodic or chronic migraine. Mm-hmm. And in addition to that, we required that they meet criteria for major depressive disorder. And we defined that by having a mental health professional do a psychiatric evaluation and assign a diagnosis based on DSM-5 criteria for major depressive disorder.
Were any of these individuals taking psychiatric medications for any of this in your cohorts?
Yeah, so some of them were, but they had to have a level of depression sufficiently severe so that we thought we would have an ability to improve it. So, sometimes if someone with major depressive disorder goes on an antidepressant, their depression remits and they no longer meet criteria. So everyone who enrolled had to meet criteria for depression.
And the main outcome you were looking for was mean from change baseline in monthly migraine days?
Right. So the primary outcome was change in monthly migraine days over the initial 12 weeks of treatment with Fremanezumab versus placebo. But as secondary endpoints, we had the Hamilton D17, which is a widely used scale for assessing depression used in many clinical trials. And we also included the PHQ-9, which is a standard quantitative diagnostic screener for migraine. And the reason we didn't use those tests for enrollment is if you enroll people in a study based on having a high depression score, that increases the chances of improvement in depression score due to chance alone through an effect called regression to the mean. And so we deliberately define depression one way, in the standard way, and then measured its improvement using two widely used depression scales, but designated the HAM-D as the key approach we were taking to measuring depression.
So now, with your results, before you reveal them, what were you thinking? I would assume that you're thinking, this is actually going to be a positive result. I think this is going to work for, obviously, migraine, but depression. What do you think?
Right. So I fully expected it would work with migraine because we had demonstrated that in a prior post hoc analysis. For depression, I was honestly unsure. And the reason is, depression is a brain disease, right? I mean, almost every antidepressant we use crosses the blood-brain barrier, gets into the brain, and we think it, soups up serotonin, soups up norepinephrine, soups up one of the critical neurotransmitters that we believe plays an etiologic role in depression. Fremanezumab, like other monoclonal antibodies, is at best poorly CNS penetrant. So given that it didn't get into the brain and given that we didn't demonstrate an effect on depression, I was hoping this would work. Obviously, when we do studies, we want them to be positive, but I honestly wasn't sure what we would find.
Tell us about your results.
So we found first that there was, as expected, a rather striking reduction in monthly migraine days. The magnitude of the reduction was a little more than 5 days per 4-week interval. That was significantly higher than the reduction we saw with placebo, which was 2.9 days. That difference was highly statistically significant, and a 2.2-day difference in monthly headache days is in line with what we would expect from a monoclonal antibody in a migraine trial in episodic or chronic migraine without comorbid depression. So treatment worked well for the monthly headache days. And then we also saw that there was a large and statistically significant decline in HAM-D17 scores. And we also saw that there was a statistically significant decline in the PHQ-9 score, which led us to the conclusion that treating people with episodic migraine or chronic migraine and comorbid depression, both conditions could effectively be managed with a single agent, Fremanezumab.
Right.
And what really interests me in the study is that we made depression better with a drug that doesn't get into the brain all that well, which I found a fascinating finding because when other people have approached this question, it's always with drugs that are CNS penetrant, and Fremanezumab is at best poorly penetrant.
Remarkable results. Walk with me on this because I always consider this, especially when I'm counseling my patients. Now, with migraine comes stigma and disability and difficulties in daily life. And a lot of these contribute to mood disorders and development of mood disorder. And so sometimes I think to myself, okay, well, if I just treat the migraine, then the mood disorder will improve on its own or improve as a result of migraine being treated. How much information do we have exactly with how Fremanezumab may work in this instance? Is it just because of the secondary gain from treating migraine, or is there something else? Because we do know CGRP is ubiquitous. Do you have any thoughts on the part of that?
My version of your question, which I think is closely related, is how does Fremanezumab make depression better? Does it have a direct effect on depression,
Right.
or does it improve depression because it makes migraine better?
Right.
And I think there's no question that there are what I like to call positive and negative cycles in migraine. So if somebody's in a negative cycle, their headache gets worse, maybe their sleep gets disrupted, they get more depressed. Because their sleep is disrupted and they get more depressed, they stop exercising, maybe they don't eat right, and then their headache gets worse. And when you plot headache trajectories over time, they follow this kind of roller coaster pattern where headache frequency goes up and then headache frequency goes down and then it may go up again. And I think to a great extent, the migraine roller coaster phenomenon reflects virtuous and vicious cycles. And it may be that what's happening here is that the Fremanezumab helps initiate a virtuous cycle. Headaches become less frequent, they become less severe, maybe there's less associated disability, people begin to feel better, they may socialize more, they may be more physically active, and social connection and physical activity can have an elevating effect on mood. Now, the right way of approaching this question is to look at what I would want to call the lead-lag relationships. What changes first? And because we're measuring headache with the daily diary and because we're measuring depression at frequent intervals, we could ask the question, does the improvement in headache anticipate the improvement in depression, or does it lag behind the improvement in depression? And under the hypothesis that we're making depression better by making headache better, it should be the case that the headache improves first and then the depression improves. And those analyses are planned but are not yet available. Right now I'm speculating, it's the best I can do.
Yes.
I eagerly wish to be able to answer your very important question.
I like the answer. And also, I'm looking forward to your future work on this and following up, especially because it adds to the conversation that we have with our patients and it adds to further hope and options. Do you see yourself utilizing this type of analysis for the other anti-CGRP targeting medications out there currently?
I'm planning on looking at these lead-lag relationships in some observational studies. I'm not aware of another study where a sponsor deliberately enrolled people who had migraine and met DSM criteria for major depressive disorder. I think it's an open question whether other CGRP-targeted therapies will work in this way. For me, I believe if there's evidence for a specific drug having a specific effect, using the agent which has the evidence unless there's a good reason not to. And so in patients with migraine and depression, I am preferentially using Fremanezumab now if I'm going to give a monoclonal antibody. But I don't know if galcanezumab would work the same way, but it might. I don't know if eptinezumab would work the same way, but it might.
Any closing thoughts for our listeners or neurologists, primary providers in using Fremanezumab for the future and also the results of your study?
Yeah, so there is one final point I wanted to make. We did a study a long time ago where we asked the question, what's the effect of migraine and depression on quality of life? And in that study, we showed that migraine and depression each separately result in decrements in quality of life. And we haven't shown this, but my idea is that since reduced quality of life in people with comorbid illness is driven by both the illnesses, my sense is if we make migraine better and we make depression better, we should have a greater quality of life and a greater disability impact than we would just by making migraine alone better. So I think It is important to screen people with migraine for depression because it's so common. The same can be said for anxiety, which we didn't study. And I think it's important to address both migraine and its comorbidities in our efforts to relieve pain, restore function, and improve health-related quality of life.
Thank you so much, Dr. Lipton, for your work and your colleagues. We really appreciate you joining us on the podcast today.
I would like to thank the co-investigators on the study, the many research sites that enrolled patients, and the patients who participated in the study, because that's the way we learn. Thank you so much, Dr. Armand. It was a pleasure talking to you.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. Richard Lipton about Fremanezumab in treatment of migraine and comorbid major depression. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.